Good morning. I'm Mandeep, a PhD scholar from PGI. So I'm here to present a journal club on the article entitled Family-led rehabilitation after stroke in India, an ATTEND trial, which is a randomized control trial. It's published in Lancet in June 2017, and Christian Medical College Ludhiana, PGI, and other institutes of India were a participant were a part of this clinical trial. Background. So the stroke rates are rising in low income and middle income countries, but the services are scarce. Most people with stroke in India have no access to organized rehabilitation services. So, the task shifting rehabilitation activities to unpaid caregivers might offer a sustainable alternative to conventional rehabilitation, and the effectiveness of training family members to provide stroke rehabilitation is uncertain. So, this ATTEND trial, that is a family led rehabilitation after stroke trial in India, it assessed a rehabilitation training program to deliver family led rehabilitation after stroke. Its main objective was to determine whether the family led stroke rehabilitation initiated in the hospital and continued at home would be superior to usual care in a low resource setting. They tested a hypothesis that whether a family led caregiver delivered home based rehabilitation intervention designed for an Indian context would really increase independence and survival at 6 months after stroke. The PICOT for the study population, they included stroke patients with mild to moderate disability. Intervention included family-led training intervention along with the routine rehabilitation. Comparator was usual care, and the primary outcome included the death or dependency at 6 months, that is MRS, and the secondary outcomes included shift in disability, length of hospital stay, Barthel index, caregiver burden scale, and health related quality of life scales, and WHO quality of life they considered, and Euro QOL. And also they included hospital anxiety and depression scale as secondary. So methods, settings and location, a total of 14 hospitals were across the India were a part of this trial that basically included as far as we basically know as AIMS, they include AIMS, PGI and Christian Medical College and other hospitals were included. Eligibility criteria, it was a multicentric prospective randomized open trial with blinded endpoints, that is it was a probe design. Eligibility criteria, the inclusion criteria was adults, that is stroke survivors with the age more than or equal to 18, duration less than 1 month, and they included both ischemic and hemorrhagic strokes, residual disability, expected to survive to discharge from hospital with reasonable expectation of 6 months survival, that is they would not be on palliative care or any cancerous kind of diagnostics, and were being able to provide and the stroke survivors or the caregivers who provided informed consent. Exclusion criteria included unable to identify a suitable family nominated caregiver for the training and subsequent delivery of the care, that is someone who could do the exercises for the patients at the home that could have been taught to the caregiver or to the family caregiver or even a hired caregiver by the therapist. And other was the patients or the caregivers who were unwilling to adhere to the follow up. Intervention, family rehabilitation training intervention plus routine rehabilitation initiated at home and continued initiated at hospital and continued at home. Family nominated caregiver trained by stroke coordinator health professionals, that is, they considered someone who could do the therapy for the patients. They trained the caregiver, either a family or a hired caregiver. They trained the physical therapist, that is, they called it as coordinator stroke coordinator healthcare professional. They trained the caregiver for the rehabilitation, and the rehabilitation package, it was task specific, and that included a structured checklist and cultural appropriate manual with following key points. Number 1, the information about stroke recovery trajectory, positioning and transfers and mobility. How to position, which what should be the right position of the patient, how we should transfer the patient from the bed to the wheelchair, or the other mobility or the mat activities. Then joint goal settings with the patient and nominated family caregiver and therapist, that is, the goal setting for the rehabilitation of the patient was jointly discussed, and goal was set by the therapist and the family caregiver, as well as they included the patient wherever possible. And task oriented training was done for the upper and lower upper extremity, also for the walking and the self care tasks. Within the hospital, training duration was 60-minute training per day for about 3 days, with intention of early supported discharge in addition to usual hospital care. After hospital discharge, the coordinator, they had 6 home visits to assess the progress, to continue training the caregiver, or the and to reset the goals with the patients and the caregiver. Also, they were available for the support on telephone for up to 2 months. So, this intervention included both within the hospital and after hospital discharge rehabilitation. The routine care group, that is the second group, that was the control group, that included therapy by the physical therapist during the hospital stay and post discharge, varying from no therapy or to some outpatient therapy sessions. That is, means the patient would have been told that you need the physiotherapy to be done, and it's up to the patient. If they are doing the physiotherapy, they are going to the clinic, they are asking for the home visit. Home visits, I think, would have been excluded, but the routine rehab included these two things, in clinic or no therapy, all depending on the patient. But the patient and caregiver were told about the importance of physiotherapy, and they should continue this physiotherapy. So, to ensure the fidelity of across the sites, the coordinators were collectively trained at study initiation and annual collaborator meetings, supplemented by on site training as required. Intervention training was led by the physiotherapist from India and Australia, and a log of trial intervention was kept by the coordinator for each participant for the hospital and home visit activities. Intervention patients and with their caregivers were encouraged by the coordinator to keep a daily logbook for the rehabilitation activities they performed on the patient, or the patients himself, him or herself performed for 30 days after discharge. This log of the trial was very important because this only could tell us if the patient has followed the therapy told by the therapist or they have not followed it. The control or the usual care, they receive the usual care of the rehabilitation and timelines of discharge and follow up. Overall management of the study was coordinated from the George Institute of Global Health, Sydney, Australia. Outcome measures. Outcome, as I told before, it was a modified ranking scale at 6 months, and secondary outcome included shift in disability, that is MRS, length of hospital stay, Bathel index, caregiver burden scale, health related quality of life, and hospital anxiety and depression scale. The adverse effects prescribed, pre-specific list of frequent adverse effects included death or the hospitalizations after stroke. Death could be as due to vascular, or the hospitalization could be anything due to vascular, I mean due to post recurrent stroke or infection or any other reasons for the hospital stay. Both the patients and the caregivers were given a health diary to record for the above details. That is to mention the adverse effects patient had. The caregiver were provided a diary where they could record it. Total of 1,200 patients were recruited. Randomization: the patients were randomized into intervention and control group via secured web-based central randomization system with minimization by site and stroke severity. What did they consider for the stroke severity? NIHSS less than 8 or more than or equal to 8. Minimization: what is this minimization based during randomization? It ensures excellent balance between the intervention group for specific prognostic factors. Because it was multicentric trial, so minimization was very much important to ensure that the patients in both the arms, they are almost same in the baseline measures. Blinding, prop design, it was a prop design, and the outcome measures were kept blinded for the trial intervention. Also, the patients were asked to disclose the details of home visits to blind outcome assessors to maintain confidentiality of the intervention details. Also, to address the potential unblinding, coordinators were not permitted to share an office with masked assessors, and the patient training sessions were undertaken in private room or behind the curtains. That is, any two patients who are coming at the same point to the hospital, they were blinded to each other. Means the patient who was going to the intervention group versus the patient who was going to the control group, they did not have any communication between both of them, because if they allowed it, it could have masked the effects of intervention. Because if the patient with the intervention group could have told the therapist they are receiving, it could have added on the effects, and it would have created a biasness in the results of the study. So they were blinded in these terms. To treat analysis and intention to treat analysis, as we know, we have two types of analysis: intention to treat and per protocol analysis. Intention to treat attribute it treat analysis, it attribute all the patients to the arm to which they were randomized, irrespective if they received the assigned treatment or they did not receive. All the patients who are there at the time of randomization, who were there in the baseline criteria, who were randomized, all the patients are considered for the statistical analysis. Whereas in per protocol analysis, we consider only those patients for the statistical analysis who followed the protocol. Yeah, so they did intention to treat analysis. So the concept diagram for the total of 4832 patients were screened, and 1250 were randomly assigned into intervention and control group. 263 in the intervention group, 267 in the control group, and 316 patients were included in 3-month follow up in the intervention group, and 610 were included in the 3-month follow up. A total of 607 were included in 6-month follow up, and 605 were included in the 6-month follow up for the. And intervention therapy, there was 0.23. So the primary outcome, that was the modified ranking scale at 6 month. There was again adjusted and non-adjusted analysis was done for the covariant. Adjusted analysis was done for the covariants that included study site, stroke severity, age, gender, income, and education. So for either for for the adjusted or non-adjusted analysis, the comparable proportion of the patients for MRS, it was a roughly same number of patients were dependent or died at in the both groups. That is, there was no statistically significant difference, and the results were very neutral in adjusted as well as non-adjusted analysis, with the p-value zero point 0.8. Rest for all the age, gender, for age or stroke type or stroke severity, or the caregiver type, patient education, household income, types of accommodation, all these variants showed no statistically significant difference in the intervention or the control group. So for the other secondary outcome, that for Barthel index, caregiver burden, and Nottingham extended ADL scale, there was again no statistically significant difference either at the 3 month or at 6 months. All the p-values were, more than it doesn't come up to be less than 0.05. They are all more than 0.05. And for the quality of for WHO quality of life and for EuroQOL, again there was no statistical significant difference either at 6 months or at 3 months. And for hospital anxiety and depression scale, again there was no statistically significant difference either at 3 months or 6 months. So also for the adverse effects, there was no statistically significant difference in non-fatal or fatal adverse effects. So 12% deaths occur in the intervention group, and uh, uh, and 14% in the control group. Again, it was not statistically significant. And so overall, for the infectious or other non-fatal events, even for those, there was no statistically significant difference in either control or for the length of hospital stay. The intervention, that is there was no statistically significant difference in both the groups, either the therapeutic or the routine care. So the intervention could not reduce the length of discussion. The study showed that additional family-led rehabilitation training to usual rehabilitation did not decrease the death or dependency at 6 months. That is for the primary outcome. Additionally, it did not influence on the quality of life outcomes. So it failed to reduce the length of hospital stay, and the systematic reviews for on early supported discharge after stroke and the interventions without coordination from the dedicated multidisciplinary team currently do not have any evidence of benefit. So the recover trial was also negative. Discussion: the training program might not have been sufficient to deliver the effective rehabilitation, because the time was 30 minutes per day for the intervention and 1 to 2 hours for the conventional rehabilitation. The task specific or the task shifting, that is giving the task of rehabilitation from therapist to the family caregiver, it might be not feasible and effective, because what I personally feel, even if we teach the caregivers about the therapy, but what a physical therapist do, what it I don't think it could be comparable to therapists' experience and the knowledge for doing the rehabilitation. So family dynamics might also limit the effect of strategy, and non-family generic healthcare giver maybe could be more effective strategy, or but it could but if it is effective, it could be expensive as well. So the other limitations that were not mentioned in the paper, that I would like to share in my own thoughts. For a layman to understand the physical therapeutic exercises sorry, well, so I don't think it is possible, and the manuals could not be are not maybe so sufficient for the therapist to understand the exercises. And it could have been supervised by the therapist. Even the caregiver is doing the exercises, but it could be supervised by the therapist. Behavioral techniques, that is there is there is a natural lethargy for all of us to do the exercises. No, sorry, not all of us, but most of us, to do the exercises. So maybe it was same for the patient. Suppose we have a dedicated timing for the therapist to come in the home and do the therapy, versus the caregiver is providing the therapy. Maybe they are not so compliant with the family caregivers, and there could be individual biases also, and the outcome measure also, it could they could have included the impact based. Conclusion: so the task shifting can be attractive solution for can be an attractive solution for the healthcare sustainability, but a 10 trial showed that this model of rehabilitation is ineffective, and the task shifting away from rigorous evaluation could waste limited resources. So, critical appraisal, validity assessment. Did the study address clearly focused question? Yes, PICO was well defined. Was assignment of the patient to treatment randomized? Yes, they were randomized. And are the baseline characteristics balanced between the group? Yes, the baseline between both intervention and control, they were balanced at the time of baseline. Were all the patients who entered the trial properly encountered at the conclusion? Yes, they were, because they did intention to treat analysis. And were the patients, healthcare workers, and the study personnel blinded to the treatment? Yes, they were blinded. Aside from the experimental intervention, were the groups treated equally? Yes, they were treated equally. Or as per the protocol, they mentioned that the structure of the therapy of the physical therapy protocol was same for the intervention versus the control, but not very sure if they could other covariants, that is dietary measures and medicine compliance was checked or not. So I'm not sure about that. So aside from the experimental intervention, were the group treated equally? Yes, they were treated equally. The outcome assessor was blinded, and the patient, both the groups. Confident that there was no harm as such in comparison to adverse effects and death rates. All they evaluated, but there was no difference in either of the groups. So, but the cost, we can't comment on the cost, because the cost effective analysis was not. Thank you. Thank you.